मतलब ये अगर नहीं हो गया रिवाइज टाइम पे तो कौन से टॉपिक्स पे तो पढ़ना है?
कौन से टॉपिक पढ़ने हैं? ट्रॉमा जरूर पढ़ना है, जनरल सर्जरी जरूर पढ़ना है। जीआईटी में गॉल ब्लैडर स्किप नहीं कर सकते। Fistula in ano. Fistula in ano is if this is the anal canal. In this fistula in ano, there will be a tract which communicates skin of the anal perianal region with the either rectum or the anal canal. In fistula in ano, you will find a tract communicating perianal skin and either anal canal or rectum. Now, how does a patient of fistula in ano presents? What is a classification of fistula in ano, and how do we investigate them and manage them are the things we need to know in fistula in ano. First of all, there are two classifications of fistula in ano. One is on the basis of the tract. One classification of fistula in ano is on the basis of the tract. Another classification is on the basis of internal opening. There is one classification of fistula in ano is on the basis of the tract. Another classification is on the basis of internal opening. Important is on the basis of internal opening. And the classification on the basis of the tract comes by the name of Park classification. The classification on the basis of the tract is Park classification. Right? Now, on the basis of the tract, the fistula in ano is divided into intersphincteric, transsphincteric, extrasphincteric, and supralevator. On the basis of the tract, the fistula in ano is divided into intersphincteric, transsphincteric, extrasphincteric, and supralevator. On the basis of internal opening, it is divided into low type and high type. On the basis of internal opening, it is divided into low and high type. It is called low type, important. It is called low type when the internal opening is below, important, below puborectalis muscle, like this. This is a low type of fistula. When the internal opening lies below the puborectalis muscle. High type is when the internal opening lies above the puborectalis muscle. I type is when the internal opening lies above the puborectalis muscle. And one should know low intersphincteric tie, low intersphincteric tie is the most common tie of fistula in anus. Low intersphincteric tie is the most common tie of fistula in anus. Now, how does this patient is going to present to us? The most common presentation of this patient will be perianal discharge. Patient is going to present to us with a complaint of perianal discharge, and most of the time, again a question asked, this discharge is a pus discharge. All. Perianal discharge, and most common discharge in them is pus discharge. Patient can also present with pain anal region, and patient will also have constipation. Now, any patient if comes to us with any perianal or anal problem, we know that we have to first do a per-rectal examination. And in per-rectal examination of these patients, please understand this point, you will find the external opening you can see. You can see the external opening from where the discharge is coming. So there will be external opening present. Internal opening in these patients in proctoscopy may or may not be seen. Internal opening in proctoscopy may or may not be seen. Why? If it is above the puborectalis, you will not be able to see, right? So you have an external opening, but internal opening not seen. We are suspecting now a fistula in anus. Proctoscopy, right? So you have external opening seen, internal opening not seen. So means you should start suspecting a fistula in anus, right? We have to, in fistula in anus, know where the internal opening is and how the tract of the fistula is going. We have to know the internal opening. We have to know how the tract of the fistula is going. So, to predict the internal opening, to predict the tract, there is a clinical rule also, which we need to know, called Good-Sol rule. There was a Good-Sol ligature. There is Good-Sol rule also. What is this Good-Sol rule? Let's understand. This, imagine, is the anal opening. This Good-Sol rule says that divide this anal opening by a imaginary horizontal line into two equal halves, anterior half and posterior half. Divide anal opening into two equal halves, anterior and posterior half. This rule says if the external opening of the fistula is in the anterior half, if the external opening of the fistula is in the anterior half within 3 centimeters of the anal verge, if the external opening of the fistula is in the anterior half within 3 centimeter of the anal verge, then in that case, the tract of the fistula, this rule says, is going to be straight, and the internal opening will be there in the anterior half only. If the external opening is within 3 centimeter of the anal verge in the anterior half, this rule says that the internal opening of the fistula will also be in the anterior half, and the tract of the fistula is going to be straight. Okay. It also says that if the external opening of the fistula is in the posterior half, wherever it is, if the external opening of the fistula is in the posterior half, wherever in the posterior half, the tract of the fistula is going to be curved, and the internal opening will be in midline posteriorly. I repeat, if this rule says if the external opening of the fistula is in the anterior half within 3 centimeter of the anal verge, the tract of the fistula is going to be straight, and the internal opening will be there in the anterior half itself. But if the external opening of the fistula is in the posterior half, anywhere in the posterior half, the tract of the fistula is going to be curved, and the internal opening will be there in midline posteriorly. Okay, this rule also says if the external opening of the fistula is more than 3 centimeter away from the anal verge in anterior half. It says further that if the external opening of this fistula is in the anterior half, but this time more than 3 centimeter away from the anal verge, the tract of the fistula is again going to be curved, and the internal opening in such cases will be there in the posterior half in midline. If the external opening of the fistula is more than 3 centimeter away from the anal verge in anterior half, the tract of the fistula is again going to be curved, and the internal opening will be there in midline posteriorly. This is a clinical rule to predict the tract and the opening, but then we have to confirm this. So for this, the gold standard or the most sensitive investigation is MR fistulogram now. Most sensitive investigation for fistula in ano now is MR fistulogram. And in management of fistula in ano, the management of fistula in ano depends on whether it is a low type or it is a high type. The management of fistula in ano depends whether it is a low type of fistula or a high type of fistula. In low type of fistula, we have two options: fistulotomy and fistulectomy. What is fistulotomy? Can anyone tell me? What is otomy? Otomy depends on whether it is applied on a solid thing or a hollow thing. If it is applied on a hollow thing, it is opening that hollow thing and then closing it. If it is applied on a solid thing, it is dividing it. So fistulotomy means dividing the fistula. And what is fistulectomy? Removal. Out of fistulotomy and fistulectomy, as per the latest, preferred is fistulotomy. Now you can appreciate it here. Please understand this, and you should be able to now easily understand that too. Can we do fistulotomy and fistulectomy in high type of fistula? Why? Because if you try to divide high type of fistula or you try to remove high type of fistula, you may endanger the puborectalis muscle. So there will be permanent incontinence. So we can't do that. So what do we do then in fistula, which is high type? In those cases, we have the option of sit-on insertion. We have the option of anorectal advancement flap surgery. We have the option of lift. We have sit-on insertion. We have anorectal advancement flap surgery. We have lift. Lift is ligation of intersphincteric fistulous tract. We also have the option of proximal colostomy. We also have the option of proximal colostomy. So these are the various options we have in high type of fistula. We don't need to go into the detail of these. We just need to know the preferred procedure is anorectal advancement flap surgery. Now, preferred procedure is anorectal advancement flap surgery. And you should also know this point. Sit-on insertion. This is important. Sit-on insertion, we don't need to go into the detail of sit-on insertion, but just need to know this. In patients with Crohn's disease, in patients if they have a high type of fistula, we should prefer doing a sit-on insertion. So they may provide you a HIV patient with a fistula in high type and ask you what is the treatment. And you also should know sit-on helps in cutting the fistula. It helps in draining the fistula. And it is also a marker of fistulous tract. Sit-on helps in cutting the fistula. It helps in draining the fistula. And it is also a marker of fistulous tract. Right? Then comes carcinoma anal canal. Carcinoma anal canal. Most common site, most common type. Most common site is posterior half of the anal canal. Most common type is squamous cell carcinoma. In risk factors, we should know the most important risk factor for anal malignancy is human papilloma virus. 16, 18, 31, and 33. Also, we should know anal intercourse is also a risk factor, and immunocompromised or HIV is also a risk factor. Okay, these are the three risk factors which we should know about. Now, in anal cancer, these are the points we just need to know. Investigation of choice is biopsy. Investigation of choice for local staging, if asked, it is MRI. Investigation of choice for staging in general, if asked, it is PET-CT. Investigation of choice, if asked, it is biopsy. Investigation of choice for local staging, if asked, is MRI. For in general staging, it is PET scan. Most common mode of spread is lymphatic. So if the lymph node get enlarged because of anal malignancy, which lymph node will get enlarged? Very good. So there will be inguinal lymph node enlargement. Important. Most common site of distant metastasis is lung. And again, we don't need to go into the detail of staging of this at all. We just need to know the primary modality of treatment. Primary modality of treatment for anal cancer is chemoradiation, which is also called Negro's regime. Primary modality of treatment is chemoradiation, which is also called Negro regime. वो तो मुझे पता नहीं, हो सकता है, बट मुझे नहीं पता क्या क्या रीजन है. Okay, and if after this regime, if there is a residual disease, you should do APR. What is APR? Abdominoperineal resection. Now, let me ask you a question. Think about it. जल्दबाजी नहीं करना. And answer. Okay. A patient comes to you with a complaint of something coming out of anus, right? And which occasionally bleeds also, right? And patient says that he has loss of appetite too. So you did a rectal examination. On rectal examination, you found a mass coming out of the anus. Mass coming out of the anus. The biopsy was taken. On biopsy, it was adenocarcinoma. What is the treatment of choice? Options, okay. Sorry. Sir, options के बिना आप बात नहीं करते हैं आजकल. Chemoradiation, APR, radiotherapy, conservative management. Wow. Answer. Chemoradiation. Conservative. तो दिल से आंसर नहीं करना, अभी भी बोल रहा हूँ. एग्जाम में ध्यान रखना, ये नोट्स है ना, इनको रख के जाना है, दिल से नहीं आंसर करना. प्लीज, यू आर अ गुड स्टूडेंट बट प्लीज बी केयरफुल अबाउट इट. दिल से तभी करना जब बिल्कुल ही सारे हथियार डल चुके हैं. बोलो क्यों? Who said APR? क्यों? क्यों? वेरी गुड. क्योंकि ये एडिनो कार्सिनोमा. देखो क्या है, रेक्टम का कैंसर लोअर थर्ड का एनल कैनाल से बाहर नहीं आ सकता. आ सकता है. तो अगर ये रेक्टम से अराइज हुआ कैंसर एनल कैनाल के बाहर आ गया, तो आपको कैसे पता लगेगा कि ये एनल कैनाल का कैंसर है या फिर रेक्टम का कैंसर है? बायोप्सी से. अगर ये स्क्वामस सेल है तो एनल कैनाल है, अगर ये एडिनो है तो रेक्टम है. तो अगर ये स्क्वामस सेल होता तो आंसर होता कीमोरेडिएशन. क्योंकि एडिनो बताया है इसलिए. गुड. So this is how we should go about. Then comes fissure in ano. Fissure in ano. Now, don't confuse fistula in ano with fissure in ano. Please be careful. What happens in this condition is, because of a hard fecal matter, this condition happens. The most important predisposing factor for this condition is constipation. So what happens because of constipation? A hard fecal matter comes out through the anal verge. When a hard fecal matter comes out through the anal verge, sometimes it erodes the mucosa and submucosa of the mucocutaneous junction. Mucosa and submucosa of the mucocutaneous junction of anal verge. And where does it do that? Most commonly, this erosion happens, very commonly asked question, midline posteriorly. Most of the time, this erosion happens midline posteriorly. Right? Now, the moment mucosa and submucosa gets eroded, what happens is the internal anal sphincter, which is a involuntary sphincter of anal canal, internal anal sphincter, which is a involuntary sphincter of anal canal, gets exposed. When this involuntary sphincter gets exposed, there is a spasm happens. So once the spasm happens, the anal opening further get contracted. So this problem starts with constipation, leads to further constipation. Right? So how will this patient come to you? The patient will come to you with complaint of pain during defecation. Patient can also come to us with blood streaked stool. Patient can also come to us with what is blood streaked stool? The wall of the fecal matter will have a lining of blood over on it. It's called blood streaked stool. Right? Patient can have a pipe stem stools also. And pipe stem means thin pipe-like stools, right? And diagnosis of this condition is established on visual inspection. Diagnosis of this condition is established on visual inspection. Visual inspection of the anal verge, not the patient. Patient will be constipated looking though, but then the diagnosis will be through visual inspection of the anal opening. And for rectal examination is absolutely contraindicated. If you have any sports to settle with the patient, then only do that. Right? And the treatment of this condition is to break this vicious circle of constipation. How will you break that? You'll advise patient hot fermentation, sits bath. What is sits bath? You ask the patient to sit on a warm, not hot. तो कुछ और हो जाएगा. पेशेंट को बताना पड़ता है स्पेसिफिकली कि वार्म वाटर लेना, नहीं तो बहुत कुछ करा के आ जाते हैं. Hot fermentation, warm water bath, and you should advise patient laxatives. Again, stool softness, right? Not bulk forming laxatives. And along with this, you should advise local application of smooth muscle relaxants. Right? And once you do this, the vicious circle of constipation and the muscle relaxation happens, and the spasm of the muscle goes off. And once this vicious circle gets broken, this area which got eroded, had inflammation, now got healed, and this heals by formation of a fibrosis here. Any inflammation followed by fibrosis. Now this is the weak spot. Anytime if the patient again has a hard stool coming out, there can be similar problem happening again. So with such similar attacks happening all the time, and every time you are doing this, with such multiple attacks happening, every time the inflammation and then fibrosis. So fibrosis keeps happening, and then the fibrotic tag hangs out of the anal verge. This fibrotic tag which hangs out of the anal verge is called sentinel tag. This fibrotic tag coming out of the anal verge is called sentinel tag. And this presence of this tag is a telltale sign of a chronic fissure in ano. This is a telltale sign of a chronic fissure in ano. Right? नहीं करेंगे. ठीक है, इसको ऐसे ही हील करेंगे. ठीक है. Now, this patient who has a sentinel tag, if ever develops an acute attack, again attack of acute exacerbation if happens, obviously this will be called acute on chronic. This will be called acute on chronic. the presentation of this patient, diagnosis of this patient, everything remains same. So please be careful. If a sentinel tag provided to you in a given clinical profile and the patient has an acute presentation which is corresponding to fissure in NO, the management then is going to change, because then this management alone will not be sufficient. We have to add lateral sphincterotomy. What do you mean by sphincterotomy? Divide the sphincter. Which sphincter we divide? Question asked. Which sphincter are you going to divide? Pubertalis, internal anal sphincter, external anal sphincter? Internal anal sphincter. I checked in exam. Which sphincter is to be divided here? Internal anal sphincter. And you don't need to do anything about the tag. Patient may come to you saying that the tag is still hanging. You can tell your patient that it's not a cosmetic surgery. Right? So the treatment of this condition is just this with lateral sphincterotomy. And this is all about our discussion on any doubt. So now, without washing our hands, we are going to talk about our next topic. We did. वो जब आप MR फिशलोग्राम करोगे उस पर ट्रैक दिखेगा. MRI में दिखता है. अगर स्फिंक्टर्स के दो स्फिंक्टर्स के बीच में ट्रैक जा रहा है तो इंटरस्फिंक्टरिक है. उनको ऐसे क्रॉस कर रहा है तो ट्रांसफिंक्टरिक है. लाइक दैट. Okay. So, did we do hernia in your batch? Yes, sir. So we are going to start now. Alright. Let us first talk about, and please tomorrow be prepared for a long class. Tomorrow I want your surgery to get over, right? So we can have a long duration class tomorrow. Surgical anatomy. You all know that right and left lobe of thyroid joins at isthmus to form a gland called thyroid gland. Now, can you tell me what is the blood supply of a thyroid gland? Thyroid receives its blood supply from superior thyroid artery. This superior thyroid artery is a branch of external, very good, external carotid artery. We have this inferior thyroid artery also. Inferior thyroid artery is a branch of, a question asked, inferior thyroid artery is a branch of thyrocervical trunk. Now, there was a question asked, the superior thyroid artery is related to which nerve? Vagus nerve. It is related to external laryngeal nerve. And this external laryngeal nerve is a branch of superior laryngeal nerve. Superior laryngeal nerve is superior laryngeal nerve gives two branches. internal branch and external branch. Superior laryngeal nerve gives internal and external laryngeal nerve branch. Now, first of all, let us talk about this internal laryngeal nerve. What does internal laryngeal nerve supplies? A very commonly checked thing. It gives a sensory supply to the supraglottic part of larynx. It gives a sensory supply to the supraglottic part of larynx. Now, can an internal branch of superior laryngeal nerve get injured in thyroid surgery? Yes or no? Can an internal branch of superior laryngeal nerve get injured in thyroid surgery? Yes or no? Answer is yes. But rarely. Now, if this branch gets injured, what will be the complication? It is supplying. So there will be a problem in the sensory supply. So patient has a risk of aspiration. A question asked. Right? Now, external laryngeal nerve supplies. Very good. All the muscles of the larynx are supplied by recurrent laryngeal nerve, except precothyroid, which is supplied by external laryngeal nerve. Now, can an external laryngeal nerve get injured in thyroid surgery? Yes or no? Yes or no? Answer is yes. Now, if it gets injured, what will be the problem? If this nerve gets injured, it's a nerve which is supplying precothyroid muscle, which is a tensor to the vocal cord. Important to note, this problem most of the time goes unnoticed. Because this injury will have a problem only for those who raise their note or pitch. It is also called high note now. So in a normal individual, this problem goes unnoticed. Because in our normal conversation, we don't raise our pitch. But this is a major problem for a professional or a singer. Will not be able to raise his pitch. Himesh Rishimia should have this injury. मेरे को मिल जाए दोनों काट दूँ उसमें. Acting और करता है. He is an epitome of a constipated look. और वो कॉमेडी मूवी करता है. So, to prevent injury to the external laryngeal nerve, तो कांटा लगा, उई माँ, कैसे कैसे गाने बनाते हैं लोग. लगा आती नहीं क्या नहीं आती पता नहीं. So high note now. So in this, there will be problem in raising the pitch of the voice. So in a normal individual, it goes unnoticed. Now, to prevent injury to external laryngeal nerve, in thyroid surgery, external laryngeal nerve can get injured. So to prevent injury to external laryngeal nerve, a very important and the latest thing, superior thyroid artery should be ligated as close as close or as away from the gland? Superior thyroid artery should be ligated as close or as away from the gland. The latest guideline says that superior thyroid artery en masse ligation should not be done. It is the anterior and posterior branch of superior thyroid artery. As per the latest, it says should be separately ligated and divided. So the latest guideline on superior thyroid artery ligation says superior thyroid artery should not be ligated. It is the anterior and posterior branch of superior thyroid artery should be separately ligated and divided. So if in your exam you are asked superior thyroid artery in thyroid surgery should be ligated as close, as away. If you don't have a choice of anterior and posterior branch separate ligation per se in a given choices, just for the heck of answering this question, you should take as close to the gland as possible. But as per the latest, superior thyroid artery should not be ligated. It is the anterior and posterior branch of superior thyroid artery which should be separately ligated and divided. Right? Then comes about the nerve related to inferior thyroid artery. The nerve related to inferior thyroid artery is recurrent laryngeal nerve. And you all know that recurrent laryngeal nerve supplies all the muscles of the larynx except precothyroid. So if there is a unilateral injury to the recurrent laryngeal nerve, very common question, what will be the problem? The patient will either have a weak voice or will have a hoarse voice. Either will have hoarseness of voice or will have a weak voice. But there will always be a problem in the timbre of the voice. Timbre of the voice. It will be like a Rani Mukherjee type voice. Right? And if there is a bilateral injury to recurrent laryngeal nerve, important point, once recurrent laryngeal nerve gets injured bilaterally, patient will have severe respiratory distress because of stridor. Patient will develop stridor. And to prevent injury to recurrent laryngeal nerve, this is very important. Timber के ऊपर timber ही लिखा है. थोड़ा कैलीग्राफी को अच्छा करने के लिए लिखा है. Right? So to prevent injury to recurrent laryngeal nerve, inferior thyroid artery should be ligated as close or as away. For this inferior thyroid artery now, answer is inferior thyroid artery should never be ligated. So if a question comes to an exam that inferior thyroid artery in thyroid surgery should be ligated as close, as away, at its origin, none. Answer is none now. Earlier it was as away from the gland as possible. Now it is none. Inferior means not ligated. It should never be. Why? There was also a question recently asked that why inferior thyroid artery in thyroid surgery should never be ligated. The reason of inferior thyroid artery to not ligate in thyroid surgery is there are two reasons. Out of these two reasons, the one reason is the most important reason, the first one. The major reason for not ligating it is that it's a main blood supply to a parathyroid gland. So if you ligate inferior thyroid artery, the patient will have a parathyroid ischemia. So one should never ligate inferior thyroid artery. So how will we do surgery if we don't ligate inferior thyroid artery? We will divide these capsular terminal branches. The capsular terminal branches of inferior thyroid artery should be ligated and divided, not the inferior thyroid artery. The capsular terminal branches of inferior thyroid artery should be ligated, not the main artery. Now, out of the recurrent laryngeal nerve and external laryngeal nerve, which nerve injury is more common? Very commonly asked question, and there's a lot of confusion on it. It is external laryngeal nerve injury is more common than a recurrent laryngeal nerve. Important point. Okay. क्या हुआ? अगर okay, his question is, it's a good question, and this can be a question also in exam, that you are doing a thyroid surgery and by mistake your recurrent laryngeal nerve got cut. You should not commit such mistakes first. If mistakes can happen, so if it got cut, you have to immediately repair it. You have to repair it on table. Ligate नहीं repair करेंगे. Ligate नहीं करेंगे, repair करेंगे. कहाँ ऑपरेशन देखेंगे? नहीं, फिर कुछ और कटा है. रिकरेंट laryngeal nerve कटने से ब्लड नहीं आता. तो थायराइड के ऑपरेशन में सिर्फ रिकरेंट laryngeal nerve थोड़ी कटती है, बहुत कुछ कटता है. अब रिकरेंट laryngeal nerve कटने से ब्लड क्यों आएगा? कुछ और काट दिया होगा. इतनी सारी वेसल्स हैं गले में, कुछ भी कट दिया. सो अगर स्पॉटिंग हो रही है तो कोई ब्लड वेसल इंजरी हुई, रिपेयर करें, राइट? ओके, ये एक नर्व है. ओके, कट गई. अब इन दोनों को हम कैसे जोड़ें? सूचन तो करेंगे, सूचन से तो जोड़ देंगे. Okay, now then comes, so this was about the surgical anatomy and its application. Then comes, can you tell me in physiology what are the 4 steps in formation of thyroxine? What are the 4 steps? Very commonly asked question it is. The first step is trapping of iodine. Second step is oxidation of iodide to iodine. And third step is combination of iodine with tyrosine. And the fourth step is coupling. And then you all know that T3 and T4 is released. Now, important point in this T3 and T4 release is, can you tell me which is a physiologically active form? It is T3 or T4? It is the T3 which is a physiologically active form. And out of T3 and T4, which of them has a longer half-life? Very good. Out of T3 and T4, the longer half-life is of T4. Out of T3 and T4, again important point. You know that TSH helps in release of T3 and T4. Which of them will have a negative role in negative feedback? This is important. Physiologically active form is T3, but negative feedback happens through T4. Right? Now, can you tell me what are the investigations do we have per se for thyroid evaluation? As it was the case in breast, the investigations in thyroid are broadly divided into non-invasive and invasive investigations. As it was the case in breast, the investigation in thyroid are broadly divided into invasive and non-invasive. Like the way it was in breast, invasive investigations are further divided into FNAC and biopsy. And like the way it was in breast, biopsy is further divided into core needle, incisional, and excisional. Right? 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 Wrong. Core needle and incisional biopsies in thyroid are contraindicated. Thyroid is a very vascular gland and it is present at a very important position in the neck. And these are daycare procedures. So if you do core needle or incisional biopsies, patient can have a bleeding, and because of that bleeding, there can be a compression over the trachea and the patient can die of respiratory distress. So core needle and incisional biopsies in thyroid should not be done. The only time, you should know this point also, the core needle biopsy, there is only two indications of doing core needle biopsy in thyroid. One is lymphoma of thyroid and anaplastic carcinoma. These are the two conditions where we do core needle biopsy in thyroid. But whenever we are doing a core needle biopsy in thyroid, important to note that we will do it as if we are doing a surgery on thyroid. That means we will admit the patient, we will keep the patient for 24 hours and then discharge the patient. So core needle and incisional biopsies not done in thyroid. These are the two conditions sometimes required. So that means the only biopsy in thyroid is excisional biopsy. The only biopsy in thyroid is excisional biopsy, and the minimum excisional biopsy in thyroid is hemi-thyroidectomy. Minimum biopsy in thyroid is hemi-thyroidectomy. And one thing more we should know here in invasive investigations, FNAC, important to note, in thyroid cannot differentiate between follicular adenoma and follicular thyroid carcinoma. FNAC cannot differentiate between follicular adenoma and follicular thyroid carcinoma. Why so? Checked in exam. Because to differentiate follicular adenoma from follicular thyroid carcinoma, we need to see a capsular invasion. And in FNAC, we examine cells. We don't have a capsule. So FNAC cannot differentiate follicular adenoma from follicular thyroid carcinoma. Okay. Now, so this was about the invasive investigations. Okay. Now, the non-invasive. Can you tell me any non-invasive investigation you know in thyroid? Very good. Radio iodine uptake scan, which is also called thyroid scan. And okay, just first let's enumerate, then I'll tell you things about it. Any other you can tell me? Non-invasive investigation. Imagings. Ultrasound. Very good. PET scan. Good. CT scan. Very good. Let us first know important points about this ultrasound. These are the points we need to know. I'll just quickly go through that. You already know this, but I just want you to have a clarity. Can ultrasound tell us that the thyroid gland is enlarged or not?
Yes.
Good. Can ultrasound tell us whether gland is diffusely enlarged or nodularly enlarged? Whether the gland is diffusely enlarged or there are nodules in the gland and then it's enlarged?
Yes.
It can tell us. So whether it is diffuse or nodule, it can tell us. Can it tell us that there is a single nodule or a multiple nodule?
Yes.
It can tell us. Can it tell us that the nodule which you are seeing in thyroid is solid or having a fluid inside?
Yes.
Yes. Can it tell us that there are lymph nodes in the neck are also enlarged? Yes or no? When you put a ultrasound probe in the neck, if the nodes in the neck are enlarged, can ultrasound tell us? वही बोल रहा हूँ. Enlarge it. एक मिनट भाई. बिना enlarge के कैसे दिखेगा कुछ? तो सर enlarge होगी तभी दिखेगा. तो बिना enlarge के कैसे दिखेगा? जब enlarge ही नहीं है तो क्या कैसे दिख ही नहीं सकता? किसको दिखेगा? Okay. So these are the things you can make out on ultrasound. The important one more thing. Can ultrasound guide us to do FNA?
Yes.
Can guide us? Okay. So these are the things we already knew. Now what we should know now is ultrasound can tell us all these things. But one thing which we expect ultrasound to tell us, but can't tell us in thyroid. What is that? That is the retrosternal extent of thyroid. If a gland is going retrosternally, ultrasound will not be able to tell us. Ultrasound will not be able to tell us. To know the retrosternal extent of a thyroid gland, the investigation of choice is CT scan. Please be careful about it. Investigation of choice for retrosternal extent of thyroid is CT scan. Right? Now, very important point, and this can be a question in exam. If a thyroid gland goes retrosternally, if a part of a thyroid gland goes into the mediastinum retrosternally, you all know that in the retrosternal region, means behind the sternum, there are various vessels there. In mediastinum, there are all the vessels are there. So if a gland gets enlarged and goes retrosternally, those vessels may get compressed, right? So if those vessels get compressed, there will be problem due to the compression of those vessels also, right? So we have to find out, first of all, in any patient who comes to us with a thyroid gland enlargement clinically, whether the gland is going retrosternally or not. If yes, whether it is compressing a major vessels in the retrosternum or not, we have to clinically also know. So how will we know that the gland, first of all, has gone into retrosternum or not? First of all, very important and a basic point about a thyroid clinical examination, which you should know about because clinical questions are going to be there in exam. It is said that, as a rule, you should know, any swelling, if in given question provided to you, is there in the midline of the neck. If you have any swelling in the midline of the neck, If that swelling moves with deglutition, if that swelling is moving with deglutition, it is considered as a thyroid swelling until proved otherwise. कोई भी swelling अगर neck में midline में है और अगर वो deglutition के साथ move कर रही है तो ये thyroid swelling मान ली जाती है. We will take it as a thyroid swelling. Right now, what we do when a patient comes to us, imagine with a enlargement of something in the neck, midline neck. So we'll ask the patient to extend her neck and we'll sit in front of the patient and ask the patient to do deglutition, to swallow the saliva. When the patient swallows his or her saliva, if the swelling is moving, we know we have to take it as thyroid swelling. Okay. Now, while this swelling is moving up during deglutition, we should keep observing the lower border of the swelling. Try to understand this. If the lower border of the swelling on deglutition is seen, that means thyroid has not gone retrosternal. Thyroid has not gone retrosternally. But on deglutition, if the lower border of the swelling is not seen, that means it is retrosternal. And once it is retrosternal, now we know that we have to find out whether it is causing any compression to the vessels in the retrosternum or not. Whether it is causing any compression to the retrosternal vessels or not. So for knowing that, we will do a test called Pemberton's test, which is also called Pemberton's sign. What is this Pemberton's sign? What we tell the patient, we will tell the patient to keep the head straight like this and ask him to raise his hand like this, right? For 2 to 3 minutes, right? When the patient raises his hand like this for 2 to 3 minutes, if it is compressing over the major vessels in the neck, there will be a facial puffiness happens. This is called Pemberton's sign. So what we have to understand here, what is Pemberton's sign, you have understood. Second, what we have to understand is that when to do this test. This test need not be done when the lower border of the thyroid is seen on deglutition, because the point of retrosternal is not there at all. But if the lower border of the thyroid gland is not seen, to know whether it is causing compression on the vessels, we have to do a Pemberton sign. Check through a Pemberton sign. So this is one thing we have to first know on clinical exam. 2 to 3 minutes. Right? Now, so this is about a ultrasound and investigation of choice for staging carcinoma thyroid also is CT scan. Now, thyroid scan. Important point to note, earlier we were doing thyroid scan by using iodine 123. Earlier we were doing a thyroid scan using iodine 123. Now 123. अब 131 नहीं, अब हम आयोडीन यूज ही नहीं करते हैं, अब हम करते हैं now we do a technetium 99 scan. Now we do a technetium 99 scan, and this thyroid scan, important to know, is done. The indications of thyroid scan are: 1, when there is a toxicity, associated with nodularity. When there is a toxic nodule. What do you mean by toxic nodule? Patient is hyperthyroid with a nodule in thyroid. Patient has a nodule in thyroid and having a hyperthyroid features is called toxic nodule. Second, to locate ectopic thyroid. and to locate metastatic thyroid. These are the three specific indications of thyroid scan, right? On the basis of thyroid scan, we get a hot nodule or cold nodule or a warm nodule. On the basis of thyroid scan, we get a hot, cold and a warm nodule. And out of hot, cold and warm nodule, cold nodule has the maximum risk of carcinoma and the risk is 20%. The risk of having malignancy is there in cold nodule and that risk is 20%. Okay, let me tell you. Imagine what we are doing in thyroid scan, because this is something important. See, thyroid scan is telling us whether the nodule in thyroid is hot, cold and warm. What is hot, what is cold and what is warm? देखो क्या है, ये thyroid gland है. Imagine इस thyroid gland में यहाँ पे एक nodule है. आपने clinical examination किया और clinical examination में आपको एक nodule feel हो रहा है thyroid के अंदर. ठीक है. अब हमें ये पता लगाना है कि ये nodule cold है, warm है या hot है. ठीक है. We do a thyroid scan. Up, what is this thyroid scan? Let's understand this. The first thing in thyroxine formation, that is why I told you also, is trapping of iodine. Okay, and this technetium 99 is taken up by thyroid gland as if it is taking up iodine. So, जब हम thyroid scan करते हैं technetium 99 को लेके, technetium 99 is taken up by thyroid gland as if it is taking iodine. So, when this thyroid, imagine if I do a thyroid scan in a normal individual, let's first know how the normal is going to look like. So, if I do a thyroid scan in a normal individual, because all the cells of thyroid gland are trapping iodine, so all the cells will take up iodine. So all the cells will take up technetium. So you will get in the neck in this thyroid scan a dotted butterfly, not in the tummy, but in the neck. You will get a dotted butterfly like this in the neck. Okay. Now, imagine this patient developed a nodule. Okay. I am doing a thyroid scan in this patient now. Now, if, just understand this, there can be three possibilities in this particular patient. One possibility is that this nodule is the one which is contributing to the release of thyroxine. Nodule is a one contributing to the release of thyroxine. Rest of the gland is not at all taking part in the release of thyroxine. It is the nodule which is responsible for release of this thyroxine which is there in the body. So what will happen if I do a thyroid scan in this particular patient? Instead of getting a butterfly-like structure, black butterfly-like structure in the neck, I will get this kind of a black spot at the site of the nodule. Right? When I get this kind of a black spot in the neck in thyroid scan, this is a hot nodule. The butterfly is not seen, only the nodule is seen. It is a hot nodule, right? Imagine in second scenario, the gland is the one which is contributing to the release of thyroxine and the nodule is not. Gland is contributing to the release of thyroxine, but the nodule cells are not taking part in release of thyroxine at all. So what will happen when you do a thyroid scan in this particular patient? You will get a butterfly in the neck, but at the site of the nodule, you will have a white spot. At the site of the nodule, you will get a white spot. When you get a white spot at the site of the nodule and the rest of the butterfly is seen, it is a cold nodule. It is a cold nodule. So if at the site of the nodule there is a white spot, it is cold nodule, rest of the butterfly is seen. Now if nodule and the thyroid gland both are contributing to the release of thyroxine equally, imagine this can also be a scenario. Nodule is also contributing to the release of thyroxine and the gland is also. So in that case, even the gland also will take up thyroxine, means technetium, iodine, and nodule is also going to take up iodine, means technetium. So in this patient of such on thyroid scan, you will not know, you will get a normal butterfly in the neck, you will not know through a thyroid scan that there is any nodule also or not. When you can't make out a nodule on a thyroid scan, it is a warm nodule. It is a warm nodule. Now, out of hot, cold, and warm nodule, cold nodule has a maximum chances of a malignancy. Why? Let's understand. Malignant cells, they usually don't resemble a normal cell. Malignant cells, they usually don't resemble a normal cell. So, normal cell property is to trap iodine. So, malignant cells, quite likely that they will not have a property to trap iodine. So, that means they will not take up iodine. So, they will not take up technetium. So, when they don't take up technetium, there will be a white spot. So, that is the reason why cold nodule has a maximum risk of cancer, and the risk of cancer in cold nodule is 20%. Understood now? So this is what is a thyroid scan. Okay, so we have understood these investigations, the theoretical points. Now let us understand the clinical approach. How are we going to about clinically when a patient comes to us, imagine, with a thyroid nodule. How will you say that the patient has a thyroid nodule? Any swelling in the midline of the neck, if it is moving with deglutition, it's a thyroid gland. And if in a thyroid gland there is a nodularity felt, it's a thyroid nodule, right? What will you do next? Whenever any patient comes to us with a thyroid nodule, as a rule, remember, the next step is biochemical investigation, and that is TSH. Just TSH, nothing else. No T3, no T4, just TSH. Your TSH can be normal, means the patient is euthyroid. Your patient is euthyroid. TSH can be increased, patient is hypothyroid. Hypo. TSH can be decreased, patient is hyperthyroid. Agreed? So normal and increased TSH is grouped in one category. Decreased TSH is grouped in another category. Normal and increased TSH is grouped in one category. Decreased TSH is grouped in another category. So if it is normal and increased TSH, the guideline says the next step is ultrasound. Next step is ultrasound. And after ultrasound, the next step is FNAC. Okay. Okay. If the patient has a nodule with hyperthyroid features, what will be the next step? You have just written that when there is a toxicity associated with nodularity, this is a place where we have to do a thyroid scan. So our next step will be thyroid scan. Which thyroid scan will do? Technetium-99, not radioactive iodine uptake scan. We will do technetium-99 labeled scan, right? In thyroid scan, you may have a cold nodule, you may have a hot nodule, you may have a warm nodule. Agreed? Agreed? If it is a warm nodule, then the next option is radioactive iodine 131 or anti-thyroid drugs. Rarely, sometime surgery. Most of the time we manage with anti-thyroid drugs. In hot nodule, we have radioactive iodine 131 and we have surgery. Most of the time we offer surgery. Most of the time we offer surgery. And once it is a cold nodule, the next step as per the latest, and the rest of the algorithm will run like that. Rest of the algorithm will run like that. So if you are asked what is the investigation of choice for thyroid nodule, it is FNAC. If you are asked what is the gold standard investigation for thyroid nodule, it will be excisional biopsy. And what excisional biopsy? ME thyroid. If you are asked what is the investigation of choice to differentiate benign nodule from a malignant nodule, it is again FNAC. If you are asked what is the gold standard to differentiate benign from malignant nodule, again it will be biopsy. So you have now understood the theoretical thing also and a clinical approach also. Okay, now this is a thyroid gland. This is another thyroid gland. This is another, and this is another. Right now, if I do this, what will this be? Total thyroidectomy. So when you remove both the lobes with isthmus, it is called total. Agreed? Now, if I remove this and isthmus also, so this surgery is called ME thyroidectomy. So what did I do? I did lobectomy with isthmectomy. I did lobectomy with hysterectomy. So lobectomy with hysterectomy is hemithyroidectomy. Now, if I do this, the area which I am going to shade is the area we are removing. Okay. So if I remove this, what will this surgery be? Okay, let me be very specific. What this surgery will be, this black part is going to be removed. This surgery is called subtotal thyroidectomy. What will this be? This surgery is called near total thyroidectomy. So, correct me if I'm wrong. Can I say here in subtotal thyroidectomy that I have done a subtotal lobectomy on both sides with hysterectomy? Yes or no? And can I say here that I have done lobectomy and hysterectomy with subtotal lobectomy on the other side? Yes or no? सिर्फ लिखना नहीं है, समझना भी है, because you will be checked, right? Right? Agreed? This near total thyroidectomy which I have done, you should know, is also called Hurdle-Dunhill procedure. Hurdle cell width. Right? So this is called Dunhill or Hurdle-Dunhill procedure. Okay, now, so these are the surgeries which we should know in thyroid first of all. Now, what is the most common early complication? What is the most common early complication of thyroid surgery? Very commonly asked question. The most common early complication of thyroid surgery is bleeding due to slippage of ligature. Whenever there is a slippage of ligature happens, you must be aware it is called reactionary hemorrhage. And patient won't come to you saying that your ligature got slipped. Patient will come to us with complaint. So how will a patient who has a bleeding happening due to slippage of ligature will present to us? One or हाइपोवोलेमिक शॉक पेशेंट तो बताएगा नहीं, बता देगा पेशेंट? क्या बताएगा पेशेंट? पेशेंट क्या बोलेगा? उससे पहले क्या होगा? हाइपोवोलेमिक शॉक होने से पहले क्या होगा? ट्रेकिया दब जाएगा, तो ट्रेकिया दब जाएगा तो क्या हो जाएगा? Patient will come to you with respiratory distress. So you went for an evening round after surgery. You found that your patient is complaining of respiratory distress. When you examine the wound, there is some swelling there. What will be your next step? Very important. This commonly happens. Immediately evacuate hematoma. कैसे evacuate करेंगे hematoma? इंसिजन देके, इंसिजन दिया ही हुआ है, सूचर खोल के. So immediately open sutures. Very important. Immediately open sutures and evacuate hematoma and relieve the pressure over the trachea. Then there can be other early complications also which we should know, like again a respiratory distress. This time the respiratory distress can happen because of three reasons: bilateral recurrent laryngeal nerve injury, laryngeal edema, and tracheomalacia. What is tracheomalacia? Tracheomalacia is thinning of tracheal cartilage. Thinning or softening of tracheal cartilage is tracheomalacia. Now, very important point. This is a question. In this year NEET also this was a question. यहाँ पे भी respiratory distress हो रहा है, यहाँ पे भी respiratory distress हो रहा है. अब obviously इन तीनों चीजों का मैनेजमेंट अलग होने वाला है, इसका मैनेजमेंट अलग होना था. तो कैसे पता लगे कि ये जो रेस्पिरेटरी डिस्ट्रेस हो रहा है इस बार जो हो रहा है इन तीन में से किसी के कारण है? पहली सिचुएशन में बायलैटरल रिकरेंट लैरिंजियल इंजरी में स्वेलिंग होगी. क्यों? ओके, वहां पे स्वेलिंग होगी. वेरी गुड, वेरी गुड. इनमें गुड. First of all, this respiratory distress which you will have, the scenario will be such in your exam. This respiratory distress, you will be told, is happening after the surgery in a ward. If there is a bilateral recurrent laryngeal nerve injury, if there is a laryngeal edema, if there is a tracheomalacia, this is going to be detected intraoperatively. How? Whenever a thyroid surgery is done, the anesthetists are aware. If not, they should be made aware, but they are aware that before removing the tube from the trachea, the endotracheal tube, when the patient is coming out of the anesthesia, they should check whether both the vocal cords are fluttering or not. Because if both the vocal cords are fluttering, the injury to the recurrent laryngeal nerve has not happened. But if they are not fluttering, if you remove the tube, they will be strident. When they are removing tube, they can also see a thinning of the tracheal cartilage after the removal of the thyroid gland. And laryngeal edema can also be seen. So these problems are going to be detected intraoperatively, and the solution for them is keep the endotracheal tube for long, and later on do tracheostomy. And later on do tracheostomy. Keep the endotracheal tube for long and then do the tracheostomy. This is the management of these injuries. Then there can be another early complication in thyroid surgery, which is called thyroid storm or thyrotoxic crisis. What is this thyroid storm or thyrotoxic crisis? Very good. Very good. Thyroid storm or thyrotoxic crisis happens when a hyperthyroid patient is not adequately prepared, when a hyperthyroid patient is not adequately prepared before any surgery or only thyroid surgery. Mentally? Any surgery. But what is very important for us to know, that this problem will be more common when you are doing a thyroid surgery, because that time you are manipulating a gland also, and because of manipulation of the gland, more thyroxine is going to release. So that means whenever you are subjecting any hyperthyroid patient for surgery, you have to prepare them. So how to prepare them? What is a drug of choice for preparation? A very commonly asked question. The drug of choice for preparation is carbimazole. प्रिपरेशन के लिए नहीं बोला होगा, ट्रीटमेंट के लिए बोला होगा, thyrotoxic crisis के. The drug of choice of preparation is carbimazole. Say for example, okay, let me make you understand this. Patient as a, imagine I am a hyperthyroid patient, okay, and I have some lipoma here, okay, and I want that lipoma to be excised. I come to you saying that I have a lipoma. You say it needs excision. So, but my thyroid profile is quite deranged. So you will prescribe me carbimazole, that first get your thyroid profile normal, then I'll do that, right? So I am on carbimazole and you are waiting for this, my thyroid profile to come to normal. Once it comes to normal, you will remove this lipoma, right? This lipoma was not an emergency. So you could wait for my thyroid profile to get normal. But then there can be a situation where the surgery is such where you cannot wait for long. Emergencies, you can never wait. Emergency, if happens, you have to operate whatever the status of the thyroid patient has. But if the procedure is such, which is not emergency though, but also you can't delay for long. Some malignancy, if has, you can't wait for so long that you'll get a thyroid status normal and then you'll come. So in such cases where the procedure is such where you can't wait long, there we need to add propranolol and Lugol's iodine also. So if this procedure is to be done within 10 to 15 days, we should add propranolol and Lugol's iodine also. And very important point to note, once you start propranolol, after doing a thyroidectomy in these patients, you should continue propranolol for at least 7 days. Why so? So that whatever circulating thyroxine is there in the body, the half-life of that is 7 days. So it will block the receptors of thyroxine wherever they are. The beta blockers block that, so thyroxine will not have that effect. So propranolol once started after total thyroidectomy should be continued for at least 7 days. Important point. So this is when the patient needs preparation. After total thyroidectomy. Because if you are doing some other surgery, then you have to go more longer. Right? But after total thyroidectomy, you have to at least 7. You can't stop it immediately. Then, what if the patient develops a thyrotoxic crisis? What if the patient develops a thyrotoxic crisis? First of all, it's a very bad complication to have. It's a very bad complication to have. So, immediately, patient should be shifted to ICU. What will be the presentation of this patient? You should know that. The presentation of the patient will be whatever symptoms you have in hyperthyroidism. I'm not going to go into the medicinal part of it. You know what are the symptoms in hyperthyroidism? Whatever symptoms are there in hyperthyroidism, those symptoms will be exaggerated. A hyperthyroid patient, just to make you understand, has tachycardia. These patients will have fibrillation. Hyperthyroid patients have warm extremities. This patient will have hyperthermia. So everything will be here exaggerated. So we should immediately shift them to ICU, and you should immediately start. The first drug to be started is propranolol. A question asked: what will be the first drug to be started once the patient develops a thyrotoxic crisis? It will be propranolol. But anti-thyroid drug of choice, if asked, it is propyl thiouracil. Anti-thyroid drug of choice in this condition is propyl thiouracil. क्या हो? हाँ, वो प्रिपरेशन का था, ये हो गया काम, right? So it is propyl thiouracil for treatment of this, right? Anti-thyroid drug. And not only this other drugs also may be needed. You should know what are all drugs needed in once the patient develops a thyrotoxic crisis: digoxin, diuretics, potassium iodide, and also steroids. These are the drugs may be required once the patient develops a thyrotoxic crisis. So how you will be provided this clinical profile? You will be told that a hyperthyroid patient thyroid status will be provided to you, where the TSH and T3, T4 level will be told, and you will be told that the patient underwent surgery, and after surgery patient is having a irregular heart rate, and patient is having a warm extremities, and patient is flushing, having a sweating also. What will be the next step? Or they can ask you what is the diagnosis. It is thyrotoxic crisis, and you have to immediately start propranolol. Okay. So these are the early complication. One complication which is never an early complication of thyroid surgery. Again, a question asked is hypocalcemia. This complication is never an early complication of thyroidectomy. This complication happens 3 to 5 days after thyroid surgery. Never before that. Right? And this was also one of the questions, that why does a hypocalcemia happens after thyroid surgery? There are two reasons for this hypocalcemia one should know. Question is, question क्या है? Question क्या है? Question है, why does a hypocalcemia happens? मैं कुछ और पूछ रहा हूँ. मैं ये नहीं पूछ रहा कि और बायोकेमिकल एब्नॉर्मलिटी क्या है. मैं ये पूछ रहा हूँ कि हाइपोकैल्सीमिया क्यों हो रहा है. The reason of this hypocalcemia is there are two reasons. One reason is parathyroid ischemia. Second is inadvertent removal of parathyroid along with thyroid. Inadvertent removal of parathyroids along with thyroid. Out of these two reasons, important, more common reason is parathyroid ischemia. Out of these two reasons, more common reason is parathyroid ischemia. Right? Now, once the patient develops hypocalcemia, you have to manage it. Very important discussion with this. So, this hypocalcemia is divided into mild hypocalcemia and moderate to severe hypocalcemia. What is mild and what is moderate to severe? Mild hypocalcemia is when the serum calcium of the patient is more than or equal to 7, but less than 8.5, with perioral tingling or numbness. With perioral tingling or numbness. Moderate to severe is called when the serum calcium is less than 7 or the patient has frank tetany. Because of the hypocalcemia, you must be aware that there will be the spasm of the muscles happen. It's called tetany, or there is ECG changes. It is total serum calcium, not ionized. Total serum calcium, right? In this scenario, the first line of management is oral calcium. In this scenario, the first line of management is IV calcium. Important point. And after this, in both scenarios, if the hypocalcemia persists, if the hypocalcemia is persisting, then we may need to add vitamin D here. We may need to add vitamin D and sometimes magnesium also. This is how we go about in hypocalcemia. Now let me ask you a question. Surgeon is doing a total thyroidectomy, imagine, and inadvertently a parathyroid gland got removed. Surgeon was doing a thyroidectomy and inadvertently parathyroid gland got removed. And surgeon realized that the parathyroid gland now got removed. What should surgeon do? Good. In this kind of situation, if the gland got inadvertently removed and you got to know on table, obviously if you didn't know, then you can't do anything about it. But if you got to know that gland got removed, you should chop that gland into small pieces. This is important. You should chop that gland into small pieces and now implant this gland not into the subcutaneous thing. You should implant it in the neck, in the sternocleidomastoid muscle. You should implant this gland in the sternocleidomastoid muscle when this gland got inadvertently removed. Okay, now another question. Patient underwent total thyroidectomy and got discharged. Why, sir? Nawaz Sharif. Because once you have a gland removed, you should give all the opportunity to this gland to get back to the body. How? We divide it into small pieces and put it back into the muscle. Muscles have a very good vascularity. So this gland now can have a new vascularization and can survive. Now, why are we implanting in the neck? The reason of implanting back in the neck, we will talk about that in parathyroid tomorrow. In parathyroid, we'll be discussing that. Sometime we have to implant a parathyroid gland in the brachioradialis muscle also. When to implant it in the brachioradialis muscle, we will come to know when we talk about parathyroids. But at this moment, you just need to know when a gland during thyroid surgery, a normal gland during thyroid surgery, it gets removed. You should put it back in the neck, in the muscle, sternocleidomastoid muscle, so that the gland gets the opportunity to survive. It may survive, it may not survive, but why to chop? The reason of chopping the gland is once you chop the gland, the bleeding from the gland starts happening. The vessels of the gland got opened up. And once they get opened up and when they put it in the muscle, the vascularity, it becomes easier for the gland to get the vascularity. So that is the reason. Okay. Then another question. Obviously, butcher की शॉप पे तो ले जाते हैं, काट के दो, किडनी ट्रे पे रखा उसको, नाइफ से चॉप कर दिया, right? Imagine a patient underwent a total thyroidectomy. The post-operative period of the patient was uneventful. Patient came back to you on 6th post-operative day with a complaint of carpopedal spasm. Patient has a spasm of the hand like this. This is called carpopedal spasm. Right? Patient comes to you with like this. You did a biochemical evaluation of the patient. Serum calcium of the patient was found to be 7.5. What will be your next step? Choices are oral calcium, IV calcium, oral calcium with vitamin D3, IV calcium with vitamin D. 7.5. We should start IV calcium. Patient who has a serum calcium in between this, it is between 7 to 8.5 though. But if it is with this, then it is oral calcium. Once the patient is showing signs of tetany, even if the serum calcium is more than 7, you have to start IV calcium. Another question. Imagine a patient comes to you, the same patient this time comes to you with a complaint of perioral tingling. रुक जाओ, एग्जाम में ये गलती नहीं होनी चाहिए. Have patience. क्वेश्चन पूरा सुनो, समझो, फिर आंसर करना. Right? Patient is complaining of perioral tingling. You did a biochemical evaluation. In that, serum calcium of the patient found to be 6.5. IV calcium. And remember, not with vitamin D3 at upfront. We start with oral calcium or IV calcium first. If it persists, then vitamin D3 added. Please be careful about it. So that means, that is why this OR has an importance. Understood? Now, so these are the complications. Then once you have done a total thyroidectomy to a patient will be thyroid insufficient also. Patient will be another complication. Once you have done a total thyroidectomy to a patient will be thyroid insufficient also. Obviously, thyroxine will not come, so patient will be thyroid insufficient. So for that, we have to start a replacement therapy. We have to start replacement thyroxine therapy. Replacement thyroxine therapy. So these are the complications of a thyroid surgery, right? So we'll call it a day today.
Yes, sir.
Tomorrow what? But tomorrow be prepared. Okay. No, evening class will be evening. Mostly it will be in the evening by 3:30 or 4. You will get the time. It may go till 10:30 or 11.